Hey, when you're talking about policies, maybe be mind.
I'd like to bring your attention to the Botanical Gardens leaflet with the open gardens, and our own Ellie Scott is going to be featured as one of those gardens. So make sure you get there and check that out. Just to reinforce, has everybody signed their consent for the videoing? If you haven't, please sign it and return it to the back of the room. It's just for educational purposes. It will be password protected, sent out via our GP newsletter. Now, I've got a little bit of paperwork for you tonight. Firstly, if you want to do RAC GP quick log, there's your details, and there's plenty of rooms for any notes. I'm sure you're going to be dazzled by the medical science tonight. Last two things is, once the presentations are over, it's invaluable if you fill out our RAC GP survey, so we know how the speakers hit their mark tonight. And we want contributions for what we want to hear next. So it's really important if you could do that. And lastly, a plug for the next event. You can read that at your leisure. Without further ado, our first speaker is Dr. Eugene Chung. Thank you.
All right, well, this is a bit daunting. Thank you very much for coming this evening, everyone. My name's Eugene, if you haven't met me. I work here in Barrel at Southern Highlands Private Hospital and Barrel District Hospital, and I live in Barrel as well now, so thank you. So what we're going to do is we're going to talk about obesity and arthroplasty today. So it won't be a hugely long topic. It's a lovely day outside, lovely evening, and we're having nice food and wine. So just starting off with disclosures and acknowledgements, what we always do. In terms of disclosures, I have none. I have no vested interests. I have no shares in any profits. I'm just a very poor orthopedic surgeon. Acknowledgements, though. I just want to acknowledge Ramsay Healthcare and Dean Engelfield here from Southern Highlands Private Hospital, the CEO, and as well Kim. I just want to mention Kim first up. She's done a lot of hard work here. It's a lot of work and a lot of effort to organize this, and for you guys to come out on a lovely evening here to listen to me waffle on for 20 minutes, half an hour. So can I just say, can we just give Kim an applause, please? All right, so we're going to kick on. Let's get rid of that. How do I get rid of that? See if it goes away. You know how to get rid of this top part here, Kim? Just the top.
Just run your mouse.
Oh, there you go. Okay. All right, so we'll see if these work. Apologize, this was made on my Mac Apple computer. Now we've gone to Microsoft, so fingers crossed won't be too many issues. So looking at the Australian population, and we're talking about the Australian population and arthroplasty. When I say arthroplasty, we're talking about, I'm going to specifically talk about hip and knee replacements. So that's when we say arthroplasty, it's kind of the medical jargon for replacements, and we're going to talk more about hip replacements and knee replacements. This is from the Australian Bureau of Statistics. What we're looking at here is the aging population in Australia. As we know, as physiotherapists and the GPs, we have an aging population, especially here in the Highlands. It is varying, but every year we have this increasing aging population, and we know that because we have a decreased fertility rate and a longer lifespan. You know, we have new medications, new advents, and people are living longer. And as well, we would think that with arthroplasty, with hip and knee replacements, we're also having an increasing trend. So these are the numbers from the Australian National Joint Registry. You can find it online. It's all free. And you can see 2 years ago, there was 58,000 hip replacements and 78,000 knee replacements. And you can see the increase, 11% and 20%, even from the year before. So it's just constantly rising, the amounts of hip and knee replacements we're doing for the elderly patients. Having said that, we have to look at the obesity issues. Now, it's become a pandemic in Australia and around the world with this increase in obesity, especially in the elderly. In Australia itself, we have the 10th highest population of, we say, overweight or obese patients, right? With 66% of adults, when they say adults, it's the age of over 15 years old, but from 15 onwards, 66% of our population is overweight, right? And that's 70% in the regional and remote areas in Australia. And you see on the graph here, the green and the kind of pinky peaches where we're overweight. And just, it's amazing that two-thirds of us are overweight. So as we know, with GPs and physiotherapists, what we use for how do we classify what's overweight, what's obese, we use the World Health Organization classification for body mass index, which has, underweight, normal again being, 18 to 25, and then we have, they call it the pre-obese. So this is where you start to get the overweight, is the over 25, right? So 25 to 30, they say, well, you're, a bit overweight. Then we get into the actual obesity classifications, where you have obese class 1, which is 30 to 35, obese class 2, 35 to 40, obese class 3, which we start calling morbidly obese. And in orthopedics, we actually have this new terminology called, are you okay? Sorry. That's okay. Carry on. We now have, in orthopedics, we now have this term called the super obese, which is like the obese of over 50. And it's happening. We also know in patients who are obese, they can have medical conditions and medical issues. And you would think with obesity, you're eating a lot, but you're not eating good food. So they're actually have poor nutrition. And we know that they have low albumin levels, they have vitamin D deficiencies, low iron transferrin levels, lymphocytes can be low, it all causes increased infections, increased other issues. And we know surgically, when you have a low albumin, less than 3.5 grams per deciliters, it's associated with poor surgical outcomes, especially wound healing. And as stated, we know there's not only these nutritional issues, we have the comorbidities with the obesity, right? Diabetes, probably the number one issue, which then leads to metabolic syndrome, also cardiovascular disease and obstructive sleep apnea. Just some of the few of the myriad issues that obese people have to face. Now, what are the specific issues in terms of hip and knee replacements with the obese? So we have to think about the preoperative issues. As we discussed before, the poor nutrition of these patients, the associated medical conditions that can make operations more challenging, more difficult. Then we look at the perioperative complications. So during the operations, you have increased risk of dislocations for hip replacements, increased risk of deep venous thrombosis, longer length of stays in hospital. You have intraoperatively a greater blood loss, longer operating times, and you have this increased cytokine response as well. Then we'll have to look at the post-operative complications. There's an increased risk of infection, which I'll discuss very shortly, a risk of prosthetic loosening, and also long-term risk of dislocation. Now, the American Association of Hip and Knee Surgeons had a workshop in 2013, so this is 15 years ago, but they say that people who are having joints with a BMI of greater than 40 should be delayed, especially in the setting of comorbid conditions. And here locally at Barrow District Hospital, we have a cutoff of less than 40 for BMI. So if we have a patient who is on the wait list, they come to pre-admissions clinic, and if they have a BMI of 40, they're denied the operation. They have to go back on the wait list, and they actually will get referred to, let's say, Campbelltown Hospital, Fairfield Hospital, which is a shame. But we have to be safe. Yes, go ahead.
Are they told that at their initial consultation?
Yes, they are, definitely, yeah. I tell all my patients when I see them, preoperatively, I have to ask them, what's your weight and height, and what's your BMI, and I try to calculate it. And I saw a patient last month who had a BMI of 47, and I said to her, look, if you've got X arthritis, but you're public, you can't get done. I'm not going to lie to you. I'm happy to put you on the wait list, but you won't get done at Barrow Hospital. Yeah. Right. So this is something we have to know. We have to have a discussion. When you see your patients, things you have to take into consideration. Yes? Yeah, so they'll be put on the wait list for other hospitals, such as Campbelltown Hospital. And the reason why is because Campbelltown has a more dedicated ICU. Yeah.
So there's no cutoff?
I don't think it's a cutoff, but I think it's more of a surgical issue as well. That's what we're going to discuss today, the concerns we have for this patient, for that patient, the obese patient.
Just going forward, if you'd like to ask a question, we'll leave the mic.
But feel free to interrupt me at any time. Just put your hand up and Kim will come running. What we're going through, I'm just going to go through some of the data. So this is hard data that comes from, the Australian Association's National Joint Registry, the NJRR. It's a yearly data that looks at every single hip and knee replacement done in Australia, and we collect all this data. It's fantastic data. Everyone can look at it online. It's hundreds and hundreds of pages of lovely nighttime reading. So we're going to talk about hip replacements. So looking at the category for BMIs in total hips, and this is from since 2014 when we started recording patient BMIs. If we look at this, the normal is only 20% of patients undergoing hip replacement have a normal weight. This is a graph form. So if you look at the graph, the normal is blue. But again, if you look at the obese, red, purple, and the kind of orangey one, that's 40% of patients going to hip replacement are obese, right? 80% of patients are at least overweight, right? So that's 80% of people going to hip replacement are overweight, not just obese, but overweight, when we know that issues. Again, the issue is revision, long-term revision. That's the issue with hip and knee replacements. Because once you have a hip or a knee replacement, you want that to last the rest of your life. That's what we hope. And that's what we tell patients. The new modern advent of technology, the prosthesis, the materials that we use should last you, 20, 25 years with a revision rate, 10 years of 5%, 10%, 7%. However, with the BMI, if you look at just at the very end, let's say it's 7 years, because at the moment we only have data for 7 years. If you look at the obese, it just goes up and up and up. So obese class 4 or greater than 40 has a 5.7% revision rate versus 2.9 in normal patients. And you see that's the graph form there. So if you look at the graph at the top right corner, the yellow, purple, and red are all the obese class 1, 2, 3. And they all have significantly higher rates of revision. All right? And this is for revision for whatever cause. But the rates of revision are dramatically increased in the obese. Now, if you look at the revision diagnosis, so if we break this up further and look at why they're being revised, again, for the obese, all right? This is the normal population, okay? So this is the normal weight. Here you can see over time, it's more fractures, people getting elderly, bones getting softer, having falls, and they're having fractures. That's more the reason for revisions for normal weight population for hip replacements. If you look at, again, class 2 and class 3 obesity, the reason why we're revising is infection, right? Which is completely avoidable. It's drastically elevated.
Sorry, Eugene?
Yes?
I'll speak loud. Why do you perceive there's a high risk of infection in the obese class 2 and 3 clients?
Yeah, well, I'll discuss that. It's a great question, Gavin. We'll get through that in a little bit. Yeah, definitely. So that was the data for hip replacements. I'm going to talk about knee replacements now. Again, from the National Joint Registry here. So we're going to talk about knee replacements now for BMI. Again, same thing. So look at knee replacements. Only 10% of the population have a normal weight undergoing knee replacement. And again, this is the same graph from the AOA Joint Registry. So again, you look at the population who are obese. It's not changing. It's not getting better, not getting worse. But approximately 60%, 60% of patients are obese. Not just overweight, but a BMI of greater than 30 undergoing a knee replacement. All right. And if you look at 90% of patients are overweight undergoing a knee replacement, so even higher than hip replacement. And we know if you look at the original stats, more patients have knee arthritis than hip arthritis. I think it was, 58,000 had a hip replacement in 2023, I think 78,000 had knee replacements. We know we're doing more knee replacements. But the patients who are knee replacements are heavier.
Eugene, sorry.
Yes. Oh, okay.
I'm just wondering if in the database it talks to how many of those patients had what in the old parlance used to be called a scrape, had some
like
sort of
knee arthroscopy, let's say.
some sort of arthroscopy.
No, it doesn't. I haven't gone to that because it's when they collect the data. So when I do a hip replacement, knee replacement, there's a form from the National Joint Registry, and you just fill it out. And basically, it's just taking demographics. It takes age of the patient. It's classified by age, weight, the reason for the operation, so osteoarthritis, rheumatoid arthritis, fracture, and that's that, but it doesn't actually say previous operation. So they may have had a car accident, or they've had arthritis, but they had a knee arthroscopy, which we now know doesn't work. But it doesn't say that, no.
Because I'm wondering whether the data from the last 15 years is heavily influenced by the high rates of arthroscopy that used to be carried out.
I have no doubt.
And that knee replacement might well fall off quite dramatically once that works its way through the population.
Look, I have no doubt it did take a part. I remember being a junior registrar, and we'd run a double theater with a consultant doing joints, and I'd be lining up and doing 10 knee scopes by myself as a second-year trainee. Just go ahead and just give it a cleanup. Just give it a cleanup. Don't worry about it. And they're all 60 years plus, and I don't think I really did them any good. But we'll find out. Yeah, we'll find out. I don't know if it's going to make a difference. Yeah, it's a good question though. All right, we'll go back. So again, we'll look at the revision rates for knee replacements. And again, if you look at the data, just looking further down, you can see with the obese, just increased revisions with the overweight, as we would expect. Again, diagnosis is a bit interesting. So again, this is the normal population. So infection is the major issue with knee replacements. It's a bit more superficial. Prosthesis, you don't have much skin and tissue before you get to the knee joint itself. So infection is the major cause of revision in the normal weight population. And again, same thing with the obese, but just an increase, crazy amounts higher. And also you can see with the green line, loosening is also seemingly higher than the normal population. So we know that there's an increased revision risk long-term with these patients. What's the acute issues? What are the acute medical complications we can see in these patients? So this is just a study from California from just last year, 2024, where they looked at the association of the super obese. So these are, give them a grain of salt, but the patients with BMI greater than 45, 50, and looking at knee replacements. And what they found was at the 90-day mark, 90 days long, just 3 months, had significantly higher risk of a joint infection, high risk of a PE, high risk of lung failure, myocardial infarction, wound dehiscence, and acute renal failure of all the super obese. And these are all statistically significant differences. What are the chronic complications? So those are within 3 months. So what are the long-term, as we know we got this increased revision rate. So there's another study from the Mayo Clinic. It's a very big orthopedic hospital in Rochester in the States. Again, look at the absolute 15 years. So we don't have 15 years data here. The Americans do. So they showed a 3-time increased risk of joint infection, and that's what correlates with our data as well. And these are actually, otherwise healthy. So they stratified these patients and said, looked at their comorbidities. So they only had one, like diabetes or sleep apnea. So these were relatively healthy, we say obesity, I'm a healthy weight. But these are relatively healthy. They classify as relatively healthy, but still class 3, class 4 obesity. And they had still a 3 times increased risk at over 15 years of an infection of the knee. So what can we do for these patients? Like, we know that hip and knee replacements are good operations for end-stage osteoarthritis. It gives a great amount of relief for them and function back to them. But we know the risks involved. What can we do as a surgeon, as a physiotherapist, as a GP for these patients? And how can we possibly lose weight for these patients? So we have to look at what's the preoperative measures in terms of what we do for a total joint. We talk about, you see a patient and they say, let's try some diet and exercise, right? We'll give you a statin, let's try, let's cut down on fatty foods, let's cut down the red meat, more leafy green vegetables. For the really obese and they want to lose weight, let's try bariatric surgery. We have a lot of bariatric surgeons now. It's a huge thing now. People are classified them as bariatric surgeons. They're just general surgeons, but now they have this subspecialty of bariatric surgery. I'm a bariatric surgeon. I have colleagues who are just bariatric surgeons. That's all they do. They don't do any other general surgery now. And then we're going to look at medications, and we're going to touch base on the new GLP-1 receptor agonist that's very popular at the moment. So weight loss. We know with weight loss, a minimum of 5 to 10% has an extremely beneficial effect for slowing down osteoarthritis. And this is what I tell my patients. If you lose weight, your knee or hip will feel better. All right. We also know not only for arthritis, just for the medical conditions, it decreases the cardiovascular risk factors, improving fasting glycemia, their HbA1c, blood pressure, and plasma lipids. And we all know this. And that's why we always hammer down, hey, let's get healthy, let's lose weight. It's going to make you better and you're going to live longer. Stop smoking, all that, right? The problem, though, is that when patients are instructed to lose weight, especially before a joint replacement, they just don't. They don't. For some reason, they actually gain weight. I don't know how it works. Like they say, oh, I can't get up anymore. I can't even get to the toilet. Like, well, they can obviously get to the fridge and back. I don't know how they do that, but they're gaining weight. I'm just being realistic. I apologize for my crassness, but only 20% of patients will lose weight when instructed. You give them the hard line and say, look, you need to lose weight. This is unhealthy for you. Let's try this, this, and this. 20% will do it. Now, bariatric surgery. It's become quite popular now. We know that it reduces the BMI, increases walking distance and the stride length in orthopedics. The issue with bariatric surgery is we don't know, the data's not out yet, and we don't know what's going to happen in terms of when a patient undergoes a joint replacement if they undergo bariatric surgery. All right? We know that post-surgically they have this in a catabolic state because they're burning, the body's not used to that. And a lot of people say now they should have a minimum of 6 months delay before having a hip or knee replacement after undergoing bariatric surgery. This is a study from Melbourne in Victoria. So it's looking at bariatric surgery in terms of the risk of total hip and knee replacements. So what they found was that significantly fewer patients in the surgery group developed postoperative complications compared to the control group. So it does seem it's beneficial, bariatric surgery. What's interesting as well, though, is that 29 patients who undergo bariatric surgery actually declined to have a knee replacement after they had surgery, right? Because they lost weight. Their knee felt better. Versus the other group, which didn't undergo bariatric surgery, only 5% wanted to be taken off the wait list, let's say. Right? So it shows you not only does it improve surgical outcomes, but you can avoid surgery, right? And this is what I tell my patients. If you can avoid surgery, avoid surgery. I'm not sure Jenny will talk about this shortly, but surgery, as we know, has multiple comorbidities and multiple complications, right? And if it's the last resort, no problems. And I have plenty of patients I'm happy to do hip and knee replacements, and they have very good results. But if we can avoid surgery, then we should avoid surgery. So again, another study from America here. They looked at patients undergoing hip replacements now who had bariatric surgery versus who didn't. And if you look at the red patients who were the control who didn't have bariatric surgery, and the green or that kind of teal colors for bariatric surgery. And this is breakdown in terms of the top 6 months, so acute complications, which I discussed before, the 3-month complications, the 2-year issues, and then 6 years. In all steps, all the bariatric patients had fewer complications than the non-bariatric surgery patients. Now, medications. So we're going to talk about the glucagon-like peptide-1 receptor agonist. Is that correct? I believe that's correct, right? We'll just say Ozempic or Wegovy, right? It's easy. We know it's been used for quite a bit, initially for diabetes, right? And that's where we use it for diabetic patients. But we now know it's exploded in the probably only the last 5 years, I'd say, even less than that. And especially with celebrities, you see in America all these celebrities drastically losing weight and denying being on medications. And I run all the time, and they're obviously on the GLPs. All right. So GPs are now being increasingly asked for these medications, like, oh, I can just take a tablet and I'll lose weight. Everyone loses weight. Oprah lost weight. I can lose weight. The issue is that these are still new medications, right? And I don't know what the data is here, so we only have limited long-term data in terms of what happens in terms of surgery, especially with arthroplasty. So if looking at arthroplasty, there's quite a few studies. So all these studies have been in the last 2 years, all right? And basically they're showing, again, we're looking just acutely. Again, we don't have the long-term data for the GLPs, but acutely we know that patients who have been on GLPs, not immediately before, but a few months before the operation and continue it, they all, again, looking at the 90-day post-op, they'll have decreased risk of infection, readmission, and hematomas. And this is all versus controls. Yeah?
You probably don't necessarily know this, but assume that the manufacturers of Ozempic and Wegovy did control studies where they did placebo. It said Ozempic on the box and it wasn't Ozempic. Is there a comparison on whether people actually lost weight against?
I think it's a proven fact that the GLPs, you lose weight. And I think if any of the GPs here, I'm happy to chat with you, I'm sure the GPs here have prescribed for their patients, they will lose weight. But you have to stay on it, that's the thing. Because they have this rebound effect with the GLP-1 RAs, where you take it, it's like one tablet a day, and you'll lose weight. But what I've read is that you have this rebound effect, where if you stop it, people say, oh, I've lost weight, I can stop the medication now. They'll just gain the weight or gain more back. Is that correct? Just in general consensus, I think most of the GPs are nodding. Yeah. So we know it works. We know it works, and you'll lose weight, but you have to constantly take it. Dean.
You've got a patient with a BMI over 40. How do you obviously assess that patient, and what information do you give them? Do you start with diet and exercise, or do you prescribe and go straight to the Wegovy and Ozempic?
Well, I won't do that myself, just because we have to look at the comorbidities, and I'm seeing them purely for their joint profile, right? And I'm not their general physician. And I think it's best I'll refer them back to the general physician and say, look, I always write a letter back to the general physician and say, thank you for referring this patient. I've seen this patient, lovely, has knee or hip arthritis, all the stuff I have to go through. And, if I say, oh, patient would probably benefit from X replacement or an operation. However, with their BMI, I'm concerned about complications. So then I believe this patient would benefit from some form of intervention prior to that to lose some weight. Yeah. Yeah, so it is a multidisciplinary, multimodal. So those are the things we can do in terms of try to lose weight before the operation. This is where Gavin, this is where you're going to talk about now. Here you ask a question. What do we do as surgeons perioperatively? So this is intra-op, immediately during the operation, immediately after. What measures do we take to minimize these risks of acute complications and long-term risks of revision? All right. So in the theater itself, we have to look at number of staff. So normally, we try to limit the number of staff we go in and out because we're trying to decrease the risk of infection. But with these patients who are like morbidly obese, you have to get them on the table. So you may need more people to physically transfer them on and off the table to be safe, right? You may need larger beds. You need like geriatric operating tables sometimes because the surgical tables that we use have a certain weight limit, and they're very strong, but sometimes they just don't work for these super obese patients. You need particular equipment in terms of how we set, some patients, if you an anterior hip, you have to be supine, but you have to make sure the patient's on the table and fits on the table. If you go posterior laterally, the patient's on the side, we call lateral decubitus. So you have to make sure the hip supports are strong enough and big enough to fit these super obese patients. Really sounds terrible. We have to look at the pannus control. So pannus control, is their abdomen. And if you're doing a hip or knee replacement, that'll get in the way in terms of the tourniquet, position, accessing the hip joint, doing an anterior approach, it's going to be right in the way. So what we do, I'm just being honest here, we'll actually get physical tape and tape the pannus away from the operative site during the operation. It's just physically shifting that weight to another area. It's just so we can actually visualize our surgical area. We have to look at pressure sore prophylaxis. This increased weight, the operation can be an hour to 3 hours long, right? And if you're sitting there, and these are gel padded operating tables, but we always position patients, we always put gel heel pads, but we have to look at how strong those are before considering the operation. VT or DVT prophylaxis, we have to look at mechanical and pharmacological interventions. So we know, normally Clexane is the gold standard, and we base it on weight. So like 40 milligrams is the weight we use, but that's based on a 70-kilogram healthy individual. If someone's 150 kilograms, we'll have to increase their postoperative Clexane dose. Mechanical, you have these calf compressors, try to use them early on. We use them during the operation. They're on during the operation when I do a hip or knee replacement as well. Antibiotic therapy, increased risk of infections, periparasitic infections, especially in the 90 days. Standard dose, we give cefazolin, which is first generation cephalosporin. We usually give it for 24 hours. Sometimes you might want to increase it 48 hours just to increase that loading of the antibiotics. surgical approach, you have to be mindful of the surgical approach. You have to see where your incision is going to be. Is it near that pannus? Is it through a large area of tissue? What's the skin like in that area? And the incision itself, you got to be very careful with. Implant selection. Certain implants are only made for certain weights, and you have to be very careful what implants you have to use. The other question, do you use cement? Do you use cement, medical cement? So it's more like a grout, but do you use medical cement versus an uncemented prosthesis, and both in hip and knee replacements? And also, just at the end, when we're closing, we got to get meticulous hemostasis, and we always do meticulous hemostasis during an operation. But I think with the obese, you have multiple layers, especially in the fat layer. And sometimes you have fat layer like this thick before getting down the hip replacement, and you cut through that, it's going to bleed, right? If you cut your skin, you bleed no matter where you get. So you have to control that bleeding, because if you don't control that bleeding with hemostasis, they're going to bleed post-operatively, and that wound will continue to bleed and ooze, and that's a harbor infection. And again, wound closure. What we use nowadays, different ways of closing the skin and the deeper layers, using a continuous suture, using barbed sutures, these new barbed sutures, which are this dissolvable barbed sutures. What we do is it's like a zipper effect. We'll just close the wound really tightly, get a really tight closure. We say watertight closure. So I know we're calling case studies. So it's just a case that I did last year, public patient. So 75-year-old female, right knee osteoarthritis, and everyone can see here, she's got bone on bone, a medial compartment there, small form of osteophytes, subconjugal sclerosis. Definitely, she has a lot of pain. She has opioids, using a walking aid now. Past medical history of just hypertension, dyslipidemia. The issue, though, her height, 155 centimeters, so shorter than me, and a weight of 89 kilograms. So BMI 37, and 37. Under 40, as Gavin, under 40, ASA 3, but it's the fat distribution, the weight distribution of these patients. If you look at his x-ray, you can see where the weight is, And sometimes you can have someone who's undergoing knee replacement have a BMI 40, but they have skinny legs. They have central, adiposity, I guess that's the word, right? Some people are central, some people are pear-shaped, these are the words that we use, apple pear-shaped, but you can see with this patient, her weight was definitely lower down. So this was a challenge. What did I do? So, set this patient up. I had multiple foot supports to hold the patient in support, because normally you use 1 or 2 foot supports just to hold it. But I knew that, with her weight, it's not going to hold it, so I used multiple supports for her. I made sure the antibiotic regime was appropriate, the appropriate dose of antibiotics. My incision, it sounds terrible, I'm actually trying to make a smaller incision that I can, because the larger incision is the high risk infection. So I make my incision whatever I need to get surgical exposure, so I can see what I need to do. And I start with a small incision, and then I'll increase it either proximally or distally if required. So I always start with a small incision first. So how does she go? The other things we can do intraoperatively, these are the post-op x-rays. What you can see here is, this is a knee replacement, but if you look on the tibia side, the distal end, you can see it's got a much more longer stem, all right? So the orthopedic acronym we say is called a stubby. It's a tibial stem, and what's that doing? Instead of normally, it would stop about there, all right? And if you look at some of the prostheses at the back from Smith & Nephew, you'll see that's what they have. And that's your standard prosthesis. What I've done here is I put a tibial stem on, because I know with her increased weight, she has an increased risk of subsidence because of the bone quality itself. So this is a cemented prosthesis, cemented on both the femur and tibia side. And I put this stem down because what it is, it distributes load further down. So it doesn't put weight purely on my surgical cut on the proximal tibia, but it distributes the load throughout. So it increases the load throughout. So I'm hoping increased revisions or increase of prosthetic loosening. So post-op, she was walking independently, not using a walking aid, not using an analgesia, and she had a range of motion of 0 to 110 degrees, which was fantastic. So I'm not trying to pat myself on the back, but the other issue with range of motion is that with patients who have you see the posterior folds, they can only flex to a certain point because of the soft tissue itself, right? Some people can only get to 90 degrees. Like theoretically, you can get to you should be 140, 150 degrees, right? But some patients can only physically get to 90 degrees because of the soft tissue impingement in the back. So I think for her, getting 110 degrees is an excellent outcome for her. So just in conclusion, the ASA, we call the Orthoplastic Society of Australia, has a position statement which you can find online. This was from a couple of years ago now. So they're saying, again, we know the prevalence of weight increases with increasing BMI. We know that joint replacement has a higher incidence of medical and surgical complications, and I discussed that today. Increased rates of revision, we know that from the Joint Registry. So this is where they talk about a clear explanation of these risks and encouragement to lose weight. And I think it's not even encouragement, but again, they say non-surgical management is recommended before joint replacement. And that's what we discussed again, right? Diet, exercise, bariatric surgery, medications. We know bariatric surgery can reduce BMI, but again, the ideal timing, minimum of 6 months, they're saying before undergoing a joint replacement after having bariatric surgery. And again, we know about the malnourishment in the multiple comorbidities with bariatric with obese patients, and that we should do some nutritional screening. So, just my take-home message. Oh, sorry, Dean. Yes, go ahead.
So you see a patient at 6 weeks. I'm assuming you'll probably see them at 12 months in some cases.
Some cases, if I'm concerned, I will. But normally, at 6 weeks, they're doing really well. In 3 months, they're doing really well. I won't see them again.
Research has been done into the post-operative course looking at weight loss at the 6 months, 12 months and seeing the impact of joint replacement on their obesity.
They don't lose weight.
I know, I need an answer.
They don't lose weight. No.
But how much do you think about the longevity of a knee replacement?
Yeah. And we know that's what we see the increased revision rate, right? So that's why I think we have to address it before the operation. That's the most important thing.
You hear from a patient that I'm having a knee replacement and I will lose weight. It never happens.
No, they said, that you won't lose weight, but you'll have better pain. So, just in conclusion for my take-home messages, we know it's a major issue. It's a pandemic issue now in Australia, throughout the world. As I said, arthroplasty hip and knee replacements are excellent operations for end-stage osteoarthritis, and it's a viable surgical operation. We do have multiple challenges and major post-operative issues for these patients. And at the end of the day, this is where discussion, that's why we're discussing throughout here as a conversation. It's not really me talking to you, but it's a conversation together about multidisciplinary, multimodal care is required. So surgeon, physician, physiotherapist, nutritionist, endocrinologist should all be involved with these patients undergoing hip or knee replacements. And thank you very much. Too close, Mike. Okay.
This one, give them the additional. Would you like to read that?
I just have a question here. So given the additional challenges with these types of patients, do you change your prehab or post-op rehab protocol for these obese patients? I wouldn't change it per se in terms of post-op recall. It's just that preoperatively, again, it's a discussion with the patient trying to lose weight, and it's a discussion with a GP, physiotherapist, and all that, as I just said beforehand. Post-operatively, we won't give them up mobilizing as soon as we can. I think that's the most important thing. Yes?
Where do you stand with regard to kneeling on a knee replacement after the surgery? Because I've heard some conflicting opinions, for example.
I don't see a problem with it. I think the issue, though, is that most surgeons, including myself, make an incision directly in front of the knee. We try to avoid going tibiotubercle, so I make my incision slightly medial to the tibiotubercle, so it's slightly not directly and right on where you kneel, tibiotubercle. It's more kind of people may have pain or discomfort over that surgical wound, the scar itself. So some surgeons now are making these really interesting kind of C-shaped incisions where it's going around the knee, and you have different access. But I know some patients don't like it because they're just used to having an incision in front of the knee, and they'll look at it and, oh, but my friend had this incision. Why do I have this crazy C-shaped incision that goes around my leg? And they just don't like it.
Yeah. Got another question over here.
The scales may be different in one of your earlier slides with your graphs of normal weight and then obese class 3 and 4. But I noticed in the normal weight people, the rate of fractures post-knee replacement was higher.
It is interesting, isn't it?
Yeah.
I think it's because they're probably using it more, to tell the truth. Yeah, they're just going out, patients with normal weight are being more active with their knee replacements, running, riding a bicycle, getting back to normal activities. Or the obese patients, they just want their pain to go away, right? And we know they're already obese, but they're not really being super active, right? They just want to get up, mobilize, and get to the car, go get the groceries, and not have pain, Right. So again, like as we stated before, we know that they don't lose weight after having a hip and knee replacement. Right. We just want to functionally get them improving so they can mobilize better. So I think that's maybe one of the reasons why.
Any last questions? Well, it's my pleasure to... we've got one from Gavin.
Yes, Gavin.
Not locally, of course, but do you know if in Sydney, for example, there's any clinics that are specialising in a multidisciplinary, either prehab approach to this with psychologists and physios and exercise physiologists and dietitians and GPs? You know,
I don't know one particularly. You'd have to look at some of the private hospitals that are large orthopedic institutions, such as the Mater Hospital. I worked at the Mater Hospital. It's pretty much a joint factory. That's what it is. They just churn out hundreds of joints a week. It's ridiculous. And I worked there as a registrar. And they have very good staff. But even when I worked and trained there as a registrar for 6 months, I did clinics there. We didn't really have, there's multidisciplinary, there's physios there because I have in-house physiotherapists, but they didn't have in-house nutritionists or endocrinologists.
Feedback saying it's...
Yes.
So you have younger patients with obesity that are having joint replacements. Is it likely their joint replacement will last their lifetime, or?
Well, no, we know with the, if you look at the revision rates, the revision is still higher. It doesn't matter what all ages. As long as you're obese, you're going to have a increased risk of revision. And again, it's mostly for infection.
But it would last them 20 years?
Theoretically, that's what we say, but again, it's a increased weight through that implant, loading multiple times, risk of the implant failure, risk of implant fracture. I've seen where actually the metal fatigues in the joint and actually can fracture. Right? You're going to have a hip replacement, and the hip replacement is usually a stem, and they have a neck and a ball, and I've seen it breaks, we call it the trunnion, and it actually snaps right off. Just bad.
Thank you, Eugene.
Thanks, guys.
The next speaker is Dr. Jenny Saunders, the Highlands' newest sports physician.
Kim? Just pressing that one. Oh, thank you. Always need good admin assistance. Thanks for coming, everybody, and it's nice to start putting faces to names. As you know, I'm new in the Highlands. I've actually been here for 3 years, and I've probably got another 50 to go before I'm local. My topic is to talk to you about the conservative management of knee osteoarthritis, but you can generalise this to other joints as well. So, predominantly my patient load will be those that are too young to consider knee replacement, or too old or too frail. So what are the alternatives that we can offer? So these all involve injection therapies for osteoarthritis, and we're assuming that these are people who have failed other modalities. They're unable to complete their physiotherapy, they can't strengthen, their pain is too great. So I'm going to talk to you about all of these 4 things, and the things that I can offer are high hyaluronic acid, platelet-rich plasma, combined platelet-rich plasma and high hyaluronic acid, and stem cell therapy. These are all proven, and they show that they work much better in the earlier stages of OA. In other words, they need to be either grade 2 or 3 on the Kellgren-Lawrence scale. And what is that? That's just an X-ray definition of grading the osteoarthritis, with 0 being normal and 4 being bone on bone and having to see Eugene. There's also a newer classification that modifies that, and it's called the MOKS thing, or the MRI classification of OA knee, and it actually looks at a lot more things than bone. So it comes up, and again, for each one of those categories, I haven't listed them all, but for each one of those categories, it's grade 0 to grade 4. And they look at every single sub part of the knee: medial femoral condyle, lateral femoral condyle, medial tibia, lateral tibia. So it's quite involved. Having said that, I have never seen a single MRI report that either comments on that score, nor have I seen X-ray reports that give you a Kellgren-Lawrence scale either. That's something I do. So HA is probably the first one that we started seeing around 20 years ago, and there's now quite a few on the market, not so many in Australia as there are in the States and in Europe, and they range from low molecular weight to high molecular weight. So the low molecular weights have more chondrocytic effect. In other words, they affect the chondrocytes to try and improve their function. And the high molecular weight give a better cushioning effect. They are produced by either an avian source or a synthetic source. The avian sources come from roosters. It's the rooster's coxcombs that is used as a source of the HA. The synthetic ones I feel are much safer, which is what I use. Both can give what's called a flare effect. It doesn't happen very often, and it usually happens when your patient doesn't do what you tell them to do. And it's just, the concerning part is it can look like an infection. So they get a red, swollen knee and it's sore. And so you have to hold your breath and hope, really, that this is not an infection. It tends to happen on recurrent injections. So these injections need to be repeated every 12 to 18 months. I have a stable of ski instructors who I see after their northern winter seasons, and they pop in before the southern winter season and they have their HA and they go on their merry way and they say, "Bye doc, see you next year." That comes from my time working so long in the snowies. So it tends to happen more with the avian sources. They're costly. It's $500 roughly for the HA itself. I use ultrasound guidance to make sure I stick it in the right place, and so there's a cost for that as well. To my knowledge, the only funds that will partially refund the HA are teachers and HCF, but you've got to have the right cover and all of those things that I don't understand. So these are the choices. Durolane is synthetic, Synvisc is avian, and Cingal is a combined synthetic with corticosteroid, and more on that later. I tend to use Durolane. I feel it's safer and I get good results. So I'm going to spend a little bit of time talking to you about platelet-rich plasma because there are a lot of myths around its use. You need to use different preparations of PRP for different issues. I have two different systems. I use one for joint, which I know I need a very high platelet count, and I use a different one for tendons and ligaments, and you can vary the amount of white cell count you have as well. So some of my colleagues, in order to reduce the cost, will use ordinary blood collection tubes. You need 6 of them, so you're taking 60 mils, you spin them down, and then you extract the buffy coat. However, that's not very exact, and you run the risk of not getting the platelets and getting too many red blood cells. And you don't want red blood cells in your knee. Just ask any haemophiliac. I use a gel-separated device for the tendons and ligaments. It gives me good platelets and low neutrophil count. And I use a flotation buoy device for higher platelet counts. And what is that? I'll just skip that slide. So when we centrifuge blood, it separates down with the red cells down here. You get a buffy coat and then plasma. So this layer of the buffy coat is where the platelets live. And you can understand if you're trying to extract that manually off 6 different tubes that you've got a very high chance of not doing that well. These two commercially available systems are flotation shelf and floating buoy. They also require a fair bit of manipulation and sometimes what's called a double spin. You'll see on this one that it is red cell contaminated. So you take that one off and you spin it again. So all of these require 20 minutes of spinning plus an extra 10. So I use a separation gel technology for some of my stuff, and we have a separating gel here. So the red cells go straight through, the neutrophils go straight through. I get left with some of the monocytes, which I want, and the platelets, and they sit right here. And it's a very easy, quick system. 10 mils of blood, 5 minutes spin time. So what are the advantages and disadvantages of platelet-rich plasma? So I'm not injecting anything foreign. Patient's own blood is used, plus a little bit of local anaesthetic. We get very good improvements. but it's expensive and it takes time to work. So we do look at the patient's own platelet count because that's one of the variables. The flotation voice shelf thing I use concentrates a platelet by a factor of 8. But if you've got a platelet count of 150,000 times 8 versus 300,000 times 8, I'm getting twice the amount of platelets in someone with a higher platelet count. And we know that in knee osteoarthritis we need to get 8 million platelets in. So I have to do a little bit of a calculation and adjust how much I'm going to stick in so I get that 8 million. There is absolutely no Medicare rebate for PRP. There used to be, but it's got rorted by, I won't say who. It's a totally private cost for the patient. It's expensive. My costs range from $660 to $850, and that's depending on the system I use and the costs of the stuff I have to use. And just as a guide, the AMA rate for ultrasound-guided injection into a joint is $650. So these are the general uses. I'm not going to talk about tendon or ligament today. So what are the practicalities? You need your patient to avoid steroidals, non-steroidals, as this can affect platelet function. Now with non-steroidals, we know we can stop them 4 days before and after. Prednisone and hydrocortisone are the biggest ones. We need to stop them for 2 weeks before and after. So I need to have a conversation with my patients to determine why are you taking these medications and is it feasible and safe to stop them. So I review my patients at 6 weeks because it's about this time that the effect should have commenced and they should be getting some pain relief and improvement in function, because they're the two things I aim for, and that's all the research talks about: pain relief and improvement in function. We do advise them to rest for 2 to 3 days post-injection. I mean, I'm using a needle to stick it in, and you need time for that to repair. And then gradual resumption of activity, and then physical therapy or EP at 2 weeks post-injection, or when the knee pain has subsided. We can expect, or we aim for, a drop of 4 points in a numerical rating scale. So if you've got a patient who's presenting with a pain score of 8, we will want to see that at 4 and hopefully even better. Contraindications are pretty important. Why is this person taking an anticoagulant? So have they got a heart valve? I'm sorry, but I can't ask them not to take their anticoagulant. So for other things, I could be able to ask them to stop their anticoagulant for a few days. Blood dyscrasias and anemia. I mean, if they're anemic, I don't want to take more blood. Interesting one is tamoxifen, and we do have quite a number of people in the community who are on tamoxifen, because for most people who are taking it for breast cancer, it's not only 5 years now, it's 10 years. So a conversation with the oncologist is always important, and we can safely stop it for up to a month and then recommence. It affects the platelet function quite significantly. And obviously I don't want to be challenging someone's immune system if they've got an infection or fever. So let's talk a few cases. Both of these cases I'm going to talk about were referred to me by people in the room. One a GP and one a physiotherapist. Mr J's 82 years young and he presents with worsening left knee pain. It's affecting his ability to look after his garden, walking and some of the more demanding housework that he tries to do. He's struggling with his physio exercises due to pain. So here are his initial x-rays. So you saw the AP weight bearing and now you can see the laterals and the patellofemoral. Sunrise views. So he opted for bilateral HA injections, and these were performed 2 weeks apart. First the left knee, which he said was his worst pain, and then the right knee. Why did we opt for HA? Because PRP loses its efficacy. The platelets aren't as good in older age. And so HA is probably a better choice for someone in this group. And 6 weeks post-injection, he reported he has decreased pain and has improved his function. So let's talk about a little bit more complicated one. This is Miss Kay. Now, she's 48 years young and she's a PE teacher. She's an absolutely fanatical cricketer and she likes to participate in other sports, particularly triathlon. She does Olympic distance, would like to. So she presents with knee pain diagnosed as early onset osteoarthritis. She feels she's too young to commit to a total knee replacement. And she's got a cricket tournament she wants to play in 10 days because the daughter's in the team and she really wants to play with the daughter. And she can't run. She tells me that there was a history of trauma in 2019 where she sustained a posterior cruciate ligament injury and fractured ankle. And she had already undergone a PRP injection to that knee in 2021, which she found very helpful. So she was quite predisposed towards having another PRP. So what did we find? She had a slight effusion. She had very little wasting of a VMO. Her range of motion was pretty good. She had some tenderness on her lateral joint line and minimal on the patellofemoral joint line. She exhibited a posterior sag for a PCL, and her X-ray showed grade 2 Kellgren-Lawrence OA in the PF joint and grade 1 KG in the lateral compartment. We discussed her options, and she elected for a combined platelet-rich replacement HA. And she was able to compete in the cricket comp, but she told me she could run, but she got pain when she tried to turn. But I'd just like to show you her imaging. This is her knee X-ray, weight bearing, and this is her MRI. And this is one of the reasons we chose the combined PRP-HA, because she has some bone edema. So PRP alone is not as good with bone edema as the combined HA-PRP. So this was the reason we chose that combination. So she came back after the tournament, very happy that she managed to play with her daughter. They didn't win, but she says she was just happy to play. She returns now with persistent medial knee pain. So before she had pain laterally and patellofemorally, anteriorly, and her knee examination was pretty similar to the previously, but less pain on lateral joint line. And this time we found tenderness over the saphenous nerve. She had quite hypertonic adductors and poor single leg stance and balance on the left. And when I started asking her about this, it's a bit of a thing of mine with sacroiliac joint, you'll get to know if you don't know already. She tells me that she's had this problem since her pregnancies. And just for the saphenous nerve, I'll just highlight it. It comes out through the adductor tunnel and is frequently compressed or impinged there. So we treated that with an injection. I don't use corticosteroid. I use a hydrodissection technique where you just strip the adherent fascia away from the nerve, and she got very good pain relief. I haven't seen her for 12 months. But, and here's the but, and this is where our colleagues come in, we need to retrain her muscle function and take away the need for those adductors to be so active. So we did look at her further. She does have a sacroiliac joint mechanical dysfunction and very altered lumbar pelvic muscle control with extremely weak gluteal musculature. So I'll just show you this. This is just to give you a diagrammatic idea of how these muscles work together and the whole kinetic chain. So this is an unstable platform. This here is the pelvis, which should be level if you stand on one leg, and hers was not. And these are just the influences of the different muscles. So this is not her, by the way, it's another patient. And all of my photographs are shown to you with patient permission. So I'm just going to show you how I check for gluteal weakness. Most of you would know about positive Trendelenburg's, but I'm going to talk to you about a compensated lateral Trendelenburg, which is not quite so bad as a Trendelenburg test. So we should get this to go. Now, standing on one leg, you should be able to stand quite straight. Watch for the sideways movement. Now you really see the sideways movement. Okay, that's telling me that she's unable to use gluteals in a single leg stance. Now remember, every time you walk, you are going to be in a single leg stance for the stance phase of that movement while you swing the other leg through. The same on running. So for an athlete, or even a recreational one, it's important that we retrain that. And when you're doing this, she's overusing adductors as well to perform that activity, which is the reason she got the saphenous nerve entrapment. Am I losing anyone? No? Good. So She did really, really well when we got her gluteals a lot stronger. So we treated the whole kinetic chain, not just the knee extensors. We treated the hip, the knee and the ankle. So I'll talk to you a little bit about... How do I do that? Oh, there it is. Okay. Oh, thank you. So I'll talk to you about stem cell therapy because you will get patients asking you about it. It's currently not accepted as a proven treatment for osteoarthritis by the TGA, Therapeutic Goods Administration. It is permitted if you're doing university trials. However, having said that, I know of many people doing it who are not doing it under university trials. We use mesenchymal stem cells in musculoskeletal medicine, and these are obtained either from adipose tissue or bone marrow. So that means you either give your patient a liposuction or you take bone marrow from the iliac crest. There are some very good studies now showing efficacy and even MR changes in the chondral surface with both of these techniques. Drawbacks: it must be performed in hospital. This is a TGA regulation, and the current data suggests that these injections last for about 5 years. They're expensive as they're unable to use their private health fund for collection of MSCs and the injection, so everything gets done in hospital. And currently they cost between 11 and 13,000 single. Some newer options on the horizon that are being investigated are donor MSCs, so we don't have to do the first bit, the collection. And I'm aware of 2 different studies underway. One I know has finished data collection and is in what's the next bit? Analysis. And the other one, they're just starting their stage 3 trials now. So they've done stage 1 and 2, and they've already proven safety, and they're now moving on to efficacy. I think that's much better. I have been trained in stem cell treatment, but I choose not to do it. And I'm waiting for the newer things where I don't have to do liposuction. So I really want to talk about the elephant in the room. Corticosteroids. Do I use them? You think I do? I don't. I really don't. Sorry, Eugene. Eugene will tell you that they do have an association with early loosening of the prosthesis if used within 6 months. They also have an association with infection. Why don't I use them? Very powerful anti-inflammatory, but they don't last and they cause problems. They're chondrocytic. They cause cell death. So PRP has been shown that at the 6 weeks, they both work out to 6 weeks, but once you get past 6 weeks, the PRP keep getting better and the people with the corticosteroid get worse. And there's 2 very large studies now that have shown anybody who's had an injection of corticosteroid into either their hip or the knee ended up having their joint replacements much earlier. So I'm talking about one study of something like 3,000 and the other one of 5. I don't like steroids. Okay, so in summary, we use biologics for the treatment of early and moderate osteoarthritis. Our choices include high hyaluronic acid, platelet-rich plasma, and a combined PRP-HA, and for some mesenchymal stem cell. So if you'd like any of the references for anything I've talked about, I can give you a full list. If you really want to know the nerdy stuff on PRP, I've just completed a how to treat for Ausdoc, and I'm not sure when it's coming out, sometime in the next 2 or 3 months. So that'll have all the complete list of references and everything. And I'm open for questions.
With the microphone.
In the sports, I know I'm talking about sports population, have you found that, I guess athletes probably have gone more to the corticosteroid to get back on the field quicker and all this sort of stuff? Are they now opting for more PRP, for obviously longer term results and more effective treatment, or do they still go to the needle for a quicker outcome?
That depends on the team doctor and how much pressure the team doctor is under. We had a really good roundtable at our last conference of sports physicians, and the overall consensus is we don't like steroids. So you're going to be hearing it from a lot more people than me. PRP actually is quite anti-inflammatory. It has something like 28 different cytokines in it that are anti-inflammatory. So you can get quite a good anti-inflammatory response initially. So I think if you talk to my cohort, we would all say, forget the steroid, go PRP.
The mic so the Zoom people can hear.
Sorry, just regards to PRP, how do you find PRP with SIJ dysfunctions?
Thank you for that lovely question. And I didn't prompt him, by the way. That's what I did my doctorate on, sacroiliac joint and PRP. In mechanical sacroiliac joint problems, we get 80% of people better with highly specialised physical therapy and restoration of optimal muscle function. Of that remaining 20%, 19.8% do well with PRP into the ligamentous portion of the SIJ. The other 0.2% are the ones who kind of will do better with surgical fusion. So I find it excellent and I use it all the time.
And sorry, just to follow up on that, do you do work cover with PRP in terms of work-related injuries for a lot of clients that we have looking at alternatives to corticosteroids or surgery?
I would like to say that I do, but they finally got me. And no, I don't. I'm happy to see them as a private patient. Most of the patients I see who are work cover patients claim back from their insurer.
Can you use the PRP for inflammatory arthritis? Or do you just use it for osteo?
There's very little data on that, but there is some data that's encouraging. It's up to the patient whether you want to give that a go or not. And I think this is where we need a lot more information because the go-to would normally be steroid, right? I'm using ketorolac, non-steroidal, injectable instead. So I've still got this thing about steroid. I would probably go to ketorolac first.
Thank you.
I might just check the chat. All good? Is there any last questions? Well, thank you to Dr. Jenny.
And I just wanted to say for those of you that I have moved to the private hospital now and I have someone to answer the phone 5 days a week, which is lovely. Thanks very much.
Thank you. Get that phone ringing. And last but not least, Dr. Tad Gunkelman, orthopaedic surgeon. Welcome.
Welcome. I never quite know what pose to strike at these things, whether I should be the orthopaedic larrikin or some sort of serious doctor. But this presentation in general is dedicated to Zara Watson's knees. So after years of jumping horses, she's here now. So this is me. It was not just Macquarie Pass, it was a long road to get here. It was, Fargo, North Dakota, Middlebury College, Lehman Brothers, College of Surgeons in Ireland, and then training in Dublin, then training in Sydney, and then doing the fellowship and the blah, blah, blah. So that's me, and that's why I have this ridiculous accent. So this is simple stuff. So what's articulate cartilage? How do we lose it? How many are affected? What can we do about it? What are the surgical options in the younger 55s? And then a bit on arthroplasty craftsmanship and how do we judge success? And we'll skip the bit about how much it costs because, yeah. So how do you lose it? This is pitched at a lower level. There's a billion different slides you could have on this, but I like to think it's either mechanical or it's medical. You're either rubbing it off or burning it off. So your cartilage is kind of funny. It doesn't like to have loads of greater than 25 millipascals. So you want to run marathons every day of your life, go for it. You'll probably increase cartilage. But you play one season of NRL and bye-bye cartilage. So the other thing is that you can injure your cartilage in a car accident at age 18 and your arthritis just shows up in your 40s and 50s. So you can x-ray both knees and one of them was injured and it's all fine, and then one of them gets it, one of it doesn't. It's a funny thing. The other one is the inflammatory arthropathies, which is where, your autoimmune reaction essentially melts it off for you. So on one side you can see the mechanical sort of thing, and on this side you're seeing a lot of bony edema, etc. So how many are affected in Australia? It's probably about 10% of us. Osteoarthritis is 62% of all the arthritides, and after age 45 it goes right up. So 22% over the age of 45 will have some form of osteoarthritis. Cities will have less than regional areas, rich people will have less than poor people. Risk factors, females get more than males, heavier people, joint misalignment, and then if you've had a previous trauma or if you've got repetitive joint loading tasks. In 2019, there were 66,500 surgical procedures, and a third of those were in New South Wales. So here, having a look here, you can see that you've got your blue males and your green females, not a lot less than 44, and then suddenly, bam, everybody gets it in their 40s and 50s, and it increases as you go up. So I won't recapitulate things that have been talked about, and there's probably a really interesting talk that we should insert in here in between injections and arthroplasty, because now there's cooled radiofrequency ablation, all these other things that we're trying to do, because arthritis is a pain thing after all, and if we can alleviate pain somehow before replacing the joint, happy days. Basically, the treatment algorithm, which was agreed by the European Society of Arthroplasty and Osteoarthritis, you get your core information, which is kind of your stage one, inform the patient, get them to take the load off, weight loss, do some exercise, try and make it right that way. Then the next stage is medical, where you're doing your analgesia and your physiotherapy, strengthening, bracing, modifying activities. And then we're into interventional stuff, which is your injections, your radiofrequency ablation, or even the last resort, which is surgical. So in the less than 55-year-old, what are your options? So traditionally, you've got the high tibial osteotomy, which is where you've decided that the person who comes in like this needs to be straighter to take the pressure off the inside. Now, it's not going to change the fact that you already have damage on this side, but by realigning the patient, the idea is to take some of the pressure off and just kick them down the road a bit before you can finally do an arthroplasty. The challenge to the HTO, of course, is that it's a multiplanar correction. Anytime you slice into the tibia and just kind of reef it up a little bit to make someone's alignment go from this to this, you have to make sure not to change their slope. You have to, not change a few other things and don't go at this side, etc. And so the advent of navigation and computer and robotics is really going to help that. But you will find that the HTO, I think, is going to sort of make a slowly graceful exit from orthopedics once you've got all these arthroplasty options, which are getting better and better. The in-between the high tibial osteotomy and the unicompartmental knee replacement is a focal arthroplasty, which is a new thing from Sweden, which is where if you have an osteochondral defect in one spot, you just kind of take out that little bit and shove in an MRI, 3D printed polished titanium implant, which is like a plug. And they have really good 5-year data, but we don't know what the data looks like after the rest of your knee dissolves and you have this big mesa sitting in the middle of your knee. Then from there, you've got into the unicompartmental knee replacement. That's these ones down here. The knee has 3 compartments: your medial compartment, your lateral compartment, and then Zara's favorite, the patellofemoral compartment. The total knee replacement is generally considered to do all 3 compartments. Now, whether or not you resurface the patella and call it, it's a bicondylar knee arthroplasty instead of a tricompartmental, whatever. A total knee replacement, is, what it looks like. That's these ones. Now, there's medial and lateral partial knee arthroplasties. There's also patellofemoral partial knee arthroplasties, but they don't tend to do as well, which is why they're not as popular, because in 7 to 10 years, you have a 50% chance of having that revised to another arthroplasty. And then finally, you have the total knee replacement, which the joint registry quite likes. It's very good for relief of pain, although your athletic 40 and 50-year-old kind of starts to wonder whether they can still do their contact sports and still do their skiing and their wave riding and everything else with their total knee. What can I do with my knee, doctor? So, the high tibial osteotomy. Yeah, go on.
Want me to speak up or use the microphone?
No, I can hear you.
Okay. It's for everyone else at home. I'm a bit older, like some of us here, so I remember the first stage of sort of unicompartmental knees and then they went out of favour for a while, and now they seem to have come back. And my observation, I think, might be that initially they were done on the younger person, trying to kick them down the road, as you say, but because the younger person was so active, they never really worked. I'm seeing them more now with a slightly older population trying to kick it down the road until they're maybe 75 or so. But that's just only my personal observation of what I'm seeing. So are you happy to quickly outline when you use a unicompartmental, at what point do you say there's no point and we're going to do a total knee replacement for reasons A, B and C?
So,
Oh, sorry, if you're going to get to it later.
No, it's fine. And I prefer chatting than didactic teaching anyway. So, traditionally, your unicompartmental knee replacement was reserved for the fat lady in her 60s, who's low demand, who has arthritis in one spot, and you're doing the uni as definitive fixation. She has varus osteoarthritis. That's it. That's all you're doing. You don't need to do a total knee replacement because she doesn't have arthritis on the other side. She doesn't have pain in the patellofemoral joint. And one of the jobs of the orthopedic surgeon when someone comes in with x-rays looking like this is to test the other compartments. For a while they were thinking, all right, as long as you don't have any changes greater than grade 2 in the other compartments, so let's do an MRI. And the MRI, of course, would say, oh yeah, it's all fine, etc. And you do a uni, and the person then, over 5, 6, 10 years, gets osteoarthritis in the other compartments, or you didn't select the patient properly and they had a little bit of patellofemoral and you did it anyway. And so then the surgeons, there's nothing more influential than your last case. So the uni comes in and goes, I got this thing now. And you're like, oh God, I got to revise the uni to a total and she's not happy and whatever else. And so then Australian surgeons, being conservative in terms of, I think more conservative rather than worldwide, they just go, well, you're either a total knee replacement or you're nothing. So we're going to kick you down the road with tablets and injections and whatever else. And then once you reach that magical age where your revision risk is 5% over the lifetime of the implant, well, then fine, I'll do it. Like crawl in on your tongue and then I'll replace your knee. So the uni has been kept out of, not kept out of Australia, but just we're conservative here. We want one and done. I don't want to see you again. And other hospital systems, like the NHS in particular, this is why it's coming back in, because they've been like, well, why are we paying for the whole knee when we could pay for half? Talk to Amr back there about what a total knee costs versus what a partial knee does. It's not 50%, but because they'd be bad businessmen if they did that. But you could get away with less, and the elderly population has varus osteoarthritis is a very common pattern. It's the most common pattern. So can you sort it out with just the partial knee replacement? And so in the NHS, where they do things according to cost and not anything else, they now have a massive case series of a whole bunch of people that they were doing unis on. And so then there's this data that's they're not as bad as we thought. You know, it's the Australian Joint Registry data is, we talk about survivorship. So how long is this knee going to last? Yeah, the patient could be crippled, morbidly unhappy, and wants to, like, essentially you've got a red dot circling you as they snipe you from the street. But if it's not a revision, it's not a failure. So the Australian Joint Registry only cares about, did we have to operate on this again? And for unis, 80% of them, 78%, are still there 20 years later. For totals, you know, about 20, I say, we got about 25-year data. The Joint Registry started in 1999. About 90 to 95% are there 25 years later. So a surgeon's going to go, well, how old are you? 70? Fine, Bob, we're going to do a total knee. Why? Because you're going to die before you're 95, and I don't have to worry about it. But there's several patients, in Barrel in particular, you've got the farmer who comes in, and he's got pain here, and he points with one finger. So never mind the sort of level 2 cartilage on the other side, never mind the total knee replacement being a panacea for all knee pain everywhere. That guy, that patient will appreciate only sorting out that one problem, that pain, and especially having the kinematics of his normal knee. So your uni patients, because you're not chopping out ACL, because you're not chopping out anything else, they recover a lot faster because, well, first of all, you're only doing half the operation, and second of all, they don't have to learn this new knee thing. They don't have to wonder, well, can I kneel? Can I do this? Of course you can. Can I ski? Of course you can. It's the same as it ever was. It's a resurfacing. That being said, Amr and I will be revising one for loosening in a 54-year-old patient who then went back to doing her squats and has popped her base plate loose. So the reason unis get revised is progression of disease, which could be bad case selection in the first place. I picked someone who had arthritis elsewhere, oops. Or loosening because you've got a smaller implant that you're gluing onto a smaller surface. So if you do arts and crafts the way my daughters do constantly at the kitchen table, you want a big broad surface area to glue stuff on. And with a total knee, you've got a big broad surface and it's going to sit right on the top. With a uni, you've got half, yeah? And you have a younger patient who's more athletic. And so then that patient is going to go back to their MMA, go back to their triathlon, go back to all these other things you promised they could do. And that's where you pop them off. So would I say, yeah, Paul, go back and do your combat cop stuff? No, because I revised him from a uni to a total after he popped it loose. Would I tell, Janelle, now that hers is loose and she probably also needs a revision? You start to edge away from the really young, really active ones, and you go towards the really young, moderately active ones. You want to ride a road bike? Yeah, it's fine with a uni. I don't know that I want you on the mat in the octagon with a uni. And you can tell patients that, and they all go, yeah, of course. And then you find them on the mat in the octagon. So sometimes you have to protect people from themselves, and if you think you've got a combat athlete or a brickie or whatever, probably a HTO, because you're not putting any parts into them. But the ebb and flow of uni versus total and what do? It's kind of this technological warfare where the totals are getting really good and the unis are a lot better than they used to be. They used to only be the Oxford, which is an awful thing to do to the medial condyle. And now that the technology and the glues and everything else is going good, you can start to solve the problem and expect better results. So patient selection, of course, is a thing, but aside from reading all the data, it's really hard to go, Bob's a good one for a uni versus Bob's a good one for a total. And I agree with you that the elderly patient can be treated satisfactorily with a uni, but we wouldn't say it's a temporizing measure where I'm going to treat this patient knowing that, 10 years down the road they're going to have a total and now they're going to need it. Like, you treat them with a uni as in, that's your definitive fixation. That is what you need, just resurfacing the medial compartment. And when they come back to you with loosening or progression of disease or whatnot, well, then you revise them. And in my practice, I've revised probably about 10% of the unis I put in because of trauma, because of combat, because of all the other stuff. And so now, would I offer the 55-year-old crazy horse jumping aficionado a uni to sort out the problem it was? And so I think case selection is probably the big thing. And it's not a panacea, but anybody that comes in and says, it's right here, and you've done all the medications, the injections, and everything else, you don't have to go to a total. You can just do the uni, and if the uni fails, it is a straightforward revision to a total, so you do have another back pocket option.
Is that a change in thought process with orthopaedic surgeons that you're doing a uni and that's a definitive need? Because I'm sure there's still a lot of thought out there that they're doing a uni to eventually move to a total knee. And so is that changing within, obviously, your colleagues and so forth?
And on that, I've heard from patients recently that, which is why I suggested that I've heard from patients recently in that age bracket that, this is to get me another 5-10 years. I haven't heard them say this is it.
Well, I would
not on your patients, but just
I don't. It's not fun revising a uni to a total. Anytime you've ever tried to re-glue something that's been glued before, you realize what a mess it looks like. You have to cut out a little bit more bone, etc. And revision totals from unis in the joint registry, which again is a very rough measure, they don't do as well as primary totals. So your uni comes into you 10 years later. I wouldn't plan to put a uni in hoping to see the patient in 10 years and complicate my life. Like, that's not what I want. And I would try to sort out definitively with a uni, the osteoarthritis, knowing in the back of my mind, okay, it's a younger patient. It may wear out faster. It's just more likely to. They're going from 50 to 100 instead of from 75 to 100. But it's definitive fixation. It's definitive arthroplasty. You're resurfacing the compartment that has the problem. Knowing that if it all goes pear-shaped, you still have a back pocket option. I can't comment on prevailing orthopedic. You put 3 orthopedic surgeons in a room, you have 50 different opinions. It's a bad idea. But overall, is the uni making a resurgence? Yeah, because the technology is making it a bit easier. The uni's always been a bit fiddly and a bit craftsmanshipy because you haven't got all the guides and all the other stuff. And robotics makes it a little bit more straightforward, etc. I don't know if that'll improve the results of it or whatnot. But Your uni patients are really happy from like week 4. Your total knee replacement patients will forgive you eventually. So, blah, blah, blah. All right, so this is high tibial osteotomy. Is essentially, you're looking at this patient here, and we're saying that there's a malalignment issue. You would drop a line from here all the way down to the ankle. You'd say, oh, look, the mechanical axis goes through the medial compartment there. You'd calculate some sort of correction. You'd crack open the medial tibia, and then you put this plate on. So basically, you're just breaking the bone to make it straight, and then bone grafting, putting a plate on. Well, yeah, it's brutal, but 6 to 12 months later, when they're done, well, then off they go, and it sort of kicks the can down the road. And the idea about pressure with cartilage is that the reason your medial compartment is wearing out is because it's getting more pressure all the time, because you're gradually coming this way, and then your weight-bearing line is skiving through the medial compartment. You're just getting more and more and more pressure, so realign. But, you know, like you say, with arthroplasty equipment getting better and technology getting better, you can just skip that whole painful 6 to 12 month process and go straight to arthroplasty. And now we're doing focal arthroplasties that are 3D printed so that it matches the perfect contour of the thing. We just don't know what that's going to be like. A lot of patients have an osteochondral defect that's symptomatic. The rest of the knee is fine, but you just don't have anything you can do with it. You can do your osteochondral allografts, you can do your microfracture, you can do all these other things, but when they come back in and say it's still painful, well, you have to throw the baby out with the bathwater. So, the uni. So, when they say ligament sparing approach, that's a fancy way of saying we don't cut anything. So the ACL stays, the PCL stays, the MCL stays, the LCL stays. So the knee kinematics are the same as it is beforehand. With a total knee replacement, your ACL goes. Every total knee replacement chops out the ACL. PCL, the MCL, the LCL, they all stay. But your ACL, which is your rotational stability in your knee, that goes. And so people have to learn their new knee in a total. Can I carve? Can I grind? Can I run and play soccer and change directions? And there's no more constraint that way. The constraint AP is by the plastic, and the constraint in rotation is by this post that sits in the middle if you're doing a PS. So with a uni, you don't do anything except just resurface the cartilage. You're looking here into a fuzzy photo of somebody's medial compartment. And this is the femur, the tibia is here, and we just put this little cap on there, and then this is an all poly tibia, which has been glued down. And so you can see that you don't have this massive honking scar there, so it's a smaller approach. There's going to be less blood loss. I wouldn't say it's less time. I fiddle a lot more with my unis than I do with my totals because I'm doing it in a smaller incision. But in general, I judge my recovery by the Oxford knee score. I take one beforehand, I take one at 6 weeks, I take one at 3 months, etc. And the Oxford knee score just tells, it's a real rough barometer. It's can you get on the bus, can you do your shopping, how much pain do you have at night, etc. But at 6 weeks, people are back into the normal from a uni, whereas with a total, it's 3 months. There's a study that showed that 85 to 90% of unis were returning to a similar higher level of sports at 1 year. 95% of those surveyed said, yeah, I do low impact stuff. 2/3 surveyed said, yeah, I do some intermediate jogging, cycling stuff. And then there were this crazy third that said, oh yeah, I'm playing footy and doing triathlons. That's at 1 year. I don't know what they're like at 5 years or 10 years. The revision risk, according to the Australian Joint Registry, over 20 years, it's probably about 78% survivorship. So this is what we get every year. It's a massive phone book, and all orthopedic surgeons get it, which is like the Australian Joint Registry report. And you can go through and you can find the stats on if you do it like this, if you do it like this, if you have this, if you have that. So this along here is the years since your primary procedure. And then you have this cumulative percent revision. How many people were revised at 1 year, at 2 year, at 3 years, or whatever. And so you look at these curves, and you'll see that for unis, this is one here is loosening. That's where it just comes unglued. Progression of disease, which I kind of think is case selection in some stages. And then you have pain, infection, and lysis. So the vast majority of unis that are being revised, and you're coming up into this 6 and 8 and 10% at 16 and 17 years, they're being revised for loosening and progression of disease. And frankly, if you've got 10% being revised for loosening and 10% being revised for progression of disease, you're looking at your 80% survivorship at 20 years. So we'll skip this. This goes a little bit to your comment, which is that there's an emerging UK and European preference for unicompartmental knee replacement. the revision rate is lower, your performance is better, you're better pre-proms. And I think that's the only way to judge satisfaction with a knee replacement is does the patient like it? Who cares what the x-ray looks like? Who cares what anything? If the patient goes, it's amazing, doc, thank you, like, it's a win. And it's a fairly straightforward revision to a TKR, although every revision is challenging. So your indications for uni traditionally are older, lower demand, sort of thinner ones. Your traditional indications for HDO is a younger, high demand, thicker patient. Your guy who's going to haul bricks. Quick word on craftsmanship. There's robotics, there's patient-specific instrumentation, there's navigation, there's conventional instrumentation, there's kinematics, there's mechanical, there's the CPA knee, there's a billion different marketing things. And the day they find out that one of those is better than all the others, we will all swap because we're not dumb. But in the meantime, we're finding that patients kind of like their knees, and you can do it this way, and you can do it this way, and you can do it that way, and a good knee is a good knee. So it all starts off with a philosophy of the surgeon. And the goals of arthroplasty are, this is Miller's Orthopedics, just saying, listen, restore their alignment, make sure you don't lower or raise the joint line by cutting wrong, make sure the soft tissue is balanced because you don't want to be sloppy on one side or the other, and then the Q angle is your patella tracking. Make sure you get your patella tracking right. There's lots of technical considerations. Do you want to do it analog with jigs? Do you want to do it with a computer assist? Do you want to do it with patient-specific instrumentation, which is where you do CT scans of your patient? They develop these sort of 3D printed foam models, and then you develop foam for the foam, and then that gets sent back to you. And the idea is that you crack open the knee, slap that thing onto the custom thing, and just cut through the hole. You don't have to worry about it. And new technology either has to make it better or faster or easier, and PSI was supposed to make it faster and easier because you don't have to size things up and pick your depths and do whatever. You just kind of take this thing which is already custom fit and go dunk, through it. But it hasn't changed. Robotics as yet hasn't changed anything, although McDessie's doing a study in Sydney trying to figure out whether robotics versus single surgeon study, robotics versus mechanical versus kinematic, trying to see whether it's better. I think they're just going to find that patients come in with pain and then you relieve it and they don't care about all the stuff that we care about. So this would be, if McDessie saw this, he'd be like, what a tosspot. He's put in a mechanical knee. How awful. Everybody knows that your joint line is a little bit oblique and it's a little bit like this and that will move much better, etc. But this patient walks into your rooms and goes, thanks, doc, and walks out. I don't care what McDessie thinks. I do, but I don't. So this is what we care about. So the definition of success is returning the patient to their desired level of function, having them forget about their knee and move on. There were traditional measures such as, can you get a range of motion from 0 to 120? Do the x-rays look good? Do I have a low revision rate? But the joint registry is now incorporating the patient-reported outcome measures. So they will ask the patient, how do you like your knee? So we have all this clinical data from 25 years, which says this revision rate, this whatever, and no one bothered to ask the patient, are you happy? Does it hurt? So when guiding patient expectations, I like to say that 85% will love their knee, 10% will like it but not love it, and the other 5% are unhappy. And in the unhappy patient, that's what all of this orthopedic, sort of contortions is about, is how do you avoid that unhappy patient? And it's a bit like you lose your car keys and you're going around looking for it and someone asks, did you find it while you're looking for it? No, I dropped it over there, but I'm looking here because the light is better. So surgeons are all about alignment and all about the technique and all about the equipment and all the whatever, and I have no idea whether that's going to solve the 5% unhappy patients. Yeah, go on.
Most of the 5% just unhappy people anyway.
I'm 100% with you. Some people carry a rain cloud with them, and I like to say that there's 4 aspects to recovery. So you've got surgery, and then you've got medicine, and then you have the patient's biology. Some people are just challenging protoplasm, and then the last one is psychology. And a big one for psychology would be like your ACL. You put an ACL into the patient, and that person is going very slowly and and that will not be a good athlete. They can't go back onto the pitch. Their psychology's been broken. They've had a flat tire and they want to drive like this now. So they don't want to hurt the knee. Will they go 110% down the pitch again on this ACL? No, I don't know. You do the job correctly, but you never got the athlete back on the pitch. Is that a fail? So yes, there are patients that are unhappy who come in, but oh my God, please don't put a knee into somebody thinking that you're going to solve this. I know a few surgeons in Sydney who will have patients who complain bitterly about this problem or that problem, and they get sent to a psychiatrist or a psychologist so that he can get a letter back and go, oh, they're not crazy, I can operate on them. And I don't know that it improves his lifestyle or anything, but basically it's saying you're constant. It doesn't match up with what's on the X-ray, So I guess things are evolving, and we're becoming a little bit more woke and friendly with orthopedics, and there's better technologies and stuff. But ultimately, we're there to break up with the patient. Like, we sell a product nobody wants. We understand that. So the patient comes in, they got pain. You do all the other stuff, they still have pain, and then you're going, replace it? That's the surgical meme. Well, you can cut it out or you can replace it. Like, what else have we got? Every bone, every joint, everything. We can cut it out or we can replace it. That's all we have. So you go through everything, and then, when you can't sort it, you then decide, well, how do I sort it? If the problem is on one side, just do the one side. If the problem is everywhere, or a little bit global, well, then do everything. And you can certainly bang total knees into every single person who comes in with a single spot and make them happy-ish. But I think you can really improve the middle-aged patient's athleticism by taking away the pain with a uni instead of a total. That being said, I don't have any study saying that this person went back to grinding, a double black, and this person didn't. An identical twin study would be perfect. Uni for you, total for you, race down the hill. But we don't have it. Any other questions? Yeah, go on.
So with the obviously the revision rates and loosening being one of those, do you think that over time that rate should decline with like improvements?
Of loosening?
Yeah.
I wish.
Or is it still this patient population there maybe high risk due to their sporting activities?
Well, there's multiple different reasons why something pops loose. It could be the mechanical forces on it. So you've glued it in and the forces on that knee are just too big. You could have a loss of continuity between the cement and the bone as other things happen and go away. Like was alluded to earlier, you inject steroids into a knee and you can loosen it over time. And in general, we don't have better cements. We don't have better, it's not an adhesive, it's a grout. And it's been the same for 25 or 30 years of the viscosity. So the cement's not the thing. The implants have changed little things. I'll put a fin here, put a peg here, put a whatever here, and that hasn't changed the revision rate. I think what you're dealing with is patient selection. You put in a uni when you should have gone with a total because there was a scuff on the patella and that was symptomatic. Or it's loosening because I think it's just too small for the forces that are put on it, or the patient's active and is going to have 20 or 30 years of that sort of activity. You could do a deep dive into, well, it says loosening, what kind of loosening, why, and I don't know whether we can subdivide these categories into something smaller. But the Oxford knee is draconian, but it has great results. The Zuck from Zimmer is pretty simple and stupid, great results. Sigma HP, one of the clunkiest sets on the market and awful to use, also has great results. You find that after a while, everybody just wants to drive the white Toyota Camry because it all converges. This is how a car lives for 30 or 40 years. And manufacturers, no offense meant, but manufacturers, they find ways to market things and to reinvent the wheel and to put it back on patent because now we have a weird curve or now we have a weird whatever. But the uni designs are all very similar and you're getting 20 years out of an athletic patient. So, you can say it's a failure in the registry, but man, 20 years for somebody who's been bashing their knee for, ever, it's not too bad. I just wish that we could tell which patients were going to abuse it or not. Do you know?
Yeah.
Because with a uni, you want to say to them, yeah, go for a run. But am I then saying, yeah, pop it loose so I can do another operation? Do you know?
And following up from that, what is harder, like a revision for a uni into a total or revising another total?
Well, I would say we hate revising totals. you're ripping things off. And if you've ever, anyway, what's a good analogy? I don't know, something glued onto something else and you rip it off and then all the other stuff comes with it and you're just looking at, and you have no more alignment tools. Do you know what I mean? You're now putting a knee into outer space. Where if you've done your cuts conservatively on a uni and then you find that you need to revise, you can just go right across and then put a total knee on the same way. However, that's not how it always happens. That Bowral farmer has one of the largest unis made, by Smith and Nephew. If I have to revise his, he's going to need an augment, which is where you put the knee on, and here's this one, and then it goes, and you have to have this big, thick base plate on one side and then the other one. So I would much rather revise a uni to a total than revise a total to a total, but I would much rather not revise anything. And I think you're less likely to revise a total. So if there's a patient that you're like, I only want to see you once, maybe a total knee replacement.
Yeah, cool. Thank you.
Any more? Is there any in the chat?
Ooh, good question.
So just put the mouse up over the green. No?
This one?
Yeah, no, don't touch that.
Don't touch that.
Chat.
Chat? Show chat, please. What do I hear?
Yeah, so, no, that was there before, so that's good. Anything else to add?
No, I don't think so.
Right, well, I'd love to thank our three wonderful speakers for the night, for giving up their time so generously. And most importantly, as well, not most importantly, as equally as important, is our generous sponsors, Smith and Nephew. Thank you for dinner. And as far as recording, so it's available for your registrars or new colleagues that come to your practices, thank you to Douglas Hanley Moore. Now, on the last page of your information, my computer's blocked, is the QR code for this RACGP survey. We'd really love your contributions. Thank you. There is dessert. Please have some. Bye.